All right, what is inflammation? It's the body's response to injury. So what happens if you go out in the sun too long and you get a sunburn? What's your body's response? Inflammation. What happens if you get an infection? Inflammation. What happens if you stub your toe? Inflammation. What happens if you drink acid? Inflammation. What happens if you spill the acid on your foot? Inflammation. What happens if you hit your thumb with a hammer? Inflammation. What happens if you have a hangnail? Inflammation. What happens if you have a paper cut? Inflammation. So no matter what kind of injury, what's your body's response? Inflammation. So the inflammatory process has a couple purposes. One of them is to contain any damage, fight off any bad things that might be present, toxins or infection, and then repair the body so that it goes back to normal. Those are the purposes of inflammation. Now, there are 4 classic signs and symptoms of inflammation, and we need to know each symptom or sign, and we need to know what causes it and why it happens. So like, what's the mechanism and what's the purpose? Now, before we move on, I keep using this word sign and symptom. What is the difference between a sign and a symptom? Wow, sounds like you guys have had health assessment. So, a sign is objective. It is something that can be observed by an outside person. A symptom is subjective. It is something a person feels. So, the very first one is erythema, which is a fancy way of saying redness. So, eryth is Latin or Greek for red. So, erythema is going to be reddened skin. Now, what do you think is the mechanism of reddened skin? What in your body is red? Blood. Okay, so how do you make the skin redder? You vasodilate. So by vasodilating, that causes more blood flow to the area. Why do we want more blood flow to the area? More antibodies, more white blood cells. What does red blood carry with it? More oxygen. So there's more of everything you need to either fight or repair tissue in your blood. So we want to vasodilate, and the purpose is to get more blood flow to that damaged area. The second one is called heat. How many of you have ever seen someone who's had a really bad sunburn? If you put your hand over their skin, a couple inches away, what do you feel? Heat radiating off their skin. So that heat is caused by vasodilation, more blood to the area, and you get more blood. How many of you have cold hands, or you know someone with really cold hands? Why do they have cold hands? It's because they have a cold heart. But it's the vasoconstriction. There's less blood flow going through their fingers. If you ever known someone who's got warm hands, they have more blood flowing through their fingers. So the warmer something is, the more blood is going through it. So it's the same reason. So vasodilation and get more blood to the area. So what do those little ticks mean? Same as the thing above it. So every now and then students are like, what does that mean? So now the third symptom is pain. Now let's talk about the purpose of pain first. What is the purpose of pain and inflammation? It's to tell you that something is wrong. Stop hurting yourself, go get help. Now, we will talk more about pain later on. It is not that simple, but for our purposes for right now, why do we get pain during inflammation? It's purposeful. It's a message. It's telling us, stop hurting yourself, go get help. Now, what's the mechanism of pain in this situation? How many of you have ever had a splinter in your finger? Now, under ordinary circumstances, you could go like this, and it wouldn't hurt at all, right? Or maybe a hangnail. You can go like that, it doesn't hurt at all. But after a hangnail, you go like that, and you're like, yeah, that hurts. Why does it hurt? Let's make it stop. Why does it hurt? And the answer is, you have sensitized pain receptors. The fancy word for a pain receptor is a nociceptor. Now again, the totality of pain is much more complicated, but this is in inflammation. The reason why we have more pain and inflammation is because of sensitized nociceptors. And that tells us, hey, something is wrong, maybe you should get some help. Any questions about any of these first three? Because those are the easy ones. This next one is a little bit harder. And it's edema, which is a fancy way of saying swelling. Now, before we can understand the purpose of edema, we have to understand the mechanism. And before we can understand the mechanism of edema, we have to understand why we don't edema in the first place. Now, how many of you are swollen up in edematous right now? Why not? I don't know. That's probably the answer for most people. I don't know. Well, that's a fine answer for now, but we're going to learn why. So, as it turns out, there are four physiological mechanisms that control the flow of fluid through tissues. And they prevent edema under ordinary circumstances. So the first thing that we're going to do is we are going to draw a little arteriole. What is an arteriole? It's the smallest artery that there is, just before you get to a capillary bed. And then on the other side of that capillary bed, we have the smallest vein that there is. And what's that called? A venule or a venule. And in between, what do you have? You have capillary bed. So that'll represent your capillaries, little capillary network. Now, what do you know about arteries? How are they different than veins? What? They have oxygenated blood. Okay, give me another example, another difference. What? Thicker walls. Why do they have thicker walls? The pumping pressure of the heart. So the heart generates a pressure that puts pressure on the walls of the artery. As it turns out, the arteriole has about 37 millimeters of water pressure on it. So that's called hydrostatic. Our first pressure is called what? Hydrostatic. Now, on the arterial side, the thing that mostly generates the hydrostatic pressure is your heart. So, on the arterial side, the thing that generates that pressure is primarily your heart. Now, on the venous side, you've used up the heart pressure, so you don't have that. But you still have some pressure pushing out because you've got fluid in the system. And over here, the major determinant of hydrostatic pressure is blood volume. Now, let's think about this for a moment. How many of you have ever owned or seen an aquarium? Now, what is the difference between a small aquarium and a large aquarium in terms of the glass? Thicker glass, the bigger it is. Why is that? Because the larger volume of water is heavier and there's more pressure. So the water is always trying to push through the walls of the aquarium. And the more water you have at the top, the more pressure there is at the bottom. So the more full your body is with fluid, the more pressure there is pushing outwards on the venous side. So on the venous side, you typically have around 17 millimeters pushing out. Okay, so you've got pressure pushing out over here, and you got pressure pushing out over here. Does that make sense? Now, There's also an osmotic pressure, which is a chemical pressure that's pulling blood inwards. And that is generated by proteins. So we're going to call that plasma osmotic pressure. Now let me ask you this question. What is the major difference between the liquid that surrounds the cells in your blood and the liquid that surrounds the cells outside of your blood? Does it have a different chemical composition, like different sodium, different potassium, or is it about the same? What's the water of your blood called, by the way? It's got a special word. Plasma. Say it like you mean it. Plasma. All right. So how is plasma different than the fluid in between your cells? It's got proteins in it. So there are plasma proteins. And what is the number one plasma protein? Albumin. So albumin plus the other ones collectively have about 25 millimeters of pressure pulling back in. Now, if you subtract 37 or 25 from 37, what's the net? (37 minus 25 is about 12. All right, so you have 12 pushing out, more or less on average over here. Does that make sense? Now, have you lost proteins through the capillary bed? So what's the osmotic pressure over here? It's the same. So 25 pulling in. So if you take 25 minus 17, what do you get? 12? No, it's not right. About 8. And that's 8 going back in. So from the arterial side, you're going to be pushing fluid out. On the venous side, you're pulling fluid back in. Not blood, just water. Does that make sense? So you're pushing water out, and then you're pulling it back in over here. Now, is there a difference between 12 and 8? Yeah, there's some left over. Somewhere between 2 to 4 millimeters of mercury are kind of left over. So over time, what do you think would happen? It would build up and you would swell up. But under ordinary circumstances, do you? No, you don't. So under ordinary circumstances, there's something else that's pulling fluid away from that area. What is that something else? The lymphatic system. So the lymphatic system is pulling away that excess fluid. So now let's think about this for a moment. We have 3 different mechanisms that can ordinarily together prevent swelling. But what happens if these things mess up? Could you have swelling? Now, the major thing that changes with hydrostatic pressure is usually you change this number over on the venous side. You increase it. Now, how could you increase venous pressure? What? Okay, more blood volume is one, and give me another one. Crossing your legs? What? Huh? Really? Crossing your legs? What is it that pumps blood back to the heart from the venous side? Random muscle movements. You learned that, right? Right? You learned that? You learned that? Yeah. Okay. What happens if a person is lying in bed all the time? Okay. So we're saying what could cause a patient to swell under ordinary circumstances out of these 3 things. So the first one is, what if we muck with hydrostatic pressure? So in order to have this balance, you have to have a certain relationship of arterial to venous pressure. What happens if venous pressure goes up? So one way to increase venous pressure is if you block venous return. So what causes venous return in the first place? It's random muscle movements. So if you have a person who's confined to bed and doesn't move, they could have increased venous pressure. Another is if they cross their legs, what are they doing to the veins in their legs? They're smushing them, and that can cause decreased venous return as well. Another possibility is if you have a tumor that is pushing on the vein as well. That's another possibility. And then someone mentioned that we have potentially increased amount of fluid. So I'll just tell you. There's 3 conditions that can typically cause an increase in the total amount of fluid in the body. The first one is kidney failure. And that makes sense. What are the kidneys' jobs? Getting rid of water. So if you have kidney failure, what are the kidneys failing to do? Get rid of water. When you don't get rid of water, you retain water, swell up. Second one is heart failure. What's the heart's job? Pump blood. Now, if the heart isn't pumping enough blood to meet the body's demands, one of the ways the body interprets that is maybe the heart doesn't have enough blood to pump in the first place. Let's help by holding on to extra fluid. And so the patient will swell up because of that. And then the third one is liver failure. And that's a little bit more complicated. We'll talk more about it in Pathopharm 2. But the 3 major things that cause fluid overload are, number 1, kidney failure, number 2, heart failure, and number 3, liver failure. So if a patient is having swelling, especially in their legs, where does gravity pull water? Down to your legs. If they're having swelling in the legs, chances are it's a problem with hydrostatic pressure. So you need to check them for those 3 failures. You need to make sure their legs aren't crossed. You may need to make sure they're having enough movement, muscle movement. Does that make sense? When you go to the hospital, you guys are going to see nurses always telling patients, uncross your legs. Uncross your legs. You have no idea how just kind of natural it is, just cross your legs in bed. Uncross your legs. But I like it. But don't do it. Because in addition to causing edema, it can actually also cause blood clots, which is a whole nother thing we'll talk about at the end of the course. So, hydrostatic pressure changes can cause edema. What are the 2 big causes of hydrostatic changes? Blockage of what? Veins. And 2, the 3 failures, fluid overload. All right, what about plasma osmotic pressure? What is it that produces plasma osmotic pressure? Plasma proteins, and the number 1 is albumin. What's the number 2? Immunoglobulins, also known as antibodies. And the third one, fibrinogen. So after that, everything else is less than 1%. So fibrinogen is about 7%. So it's like albumin is like around 45, and then immunoglobulins is like around 40, and then fibrinogen is like 7%, and everything below that's like 1% or less. So if you know the top 3, you know 99% of what you need to know. So what conditions could cause lower albumin or lower protein levels? Well, where do we get protein from anyway? From our diet? So we eat protein, our body chops it up into little, I don't know what our body does. We never had to take nutrition before. Amino acids. So you eat the protein, your body chops it up into amino acids, and then those amino acids are used in your body to make proteins. Does that sound familiar? Okay, so what if a person doesn't have enough protein in their diet? Right? So one potential cause of edema is not enough protein in the diet to make plasma proteins. Another potential cause is, well, maybe they're eating enough protein, but they can't digest it because they have some sort of digestive problem. like Crohn's disease or celiac disease. So those would be inflammatory bowel problems. Now, there's another potential reason why we might not be able to make the proteins. So you're getting enough protein in your diet, but the factory that makes the proteins ain't working right. What is the organ in charge of synthesizing albumin and most of the proteins in our body? It's a big one. What is it? The liver. Are you sure about that? Yeah. You seem more sure the first time than the second time. Yes, it's the liver. So if a person has liver disease, it's possible they might not be making enough albumin to maintain that osmotic pressure. Now, when a person has edema from decreased osmotic pressure, they tend to have swelling everywhere, not just in the legs. When it's fluid overload, where does it tend to go? To the legs, because of gravity. When it's because of decreased osmotic pressure, it tends to be everywhere. And then the last one is lymph drainage. Now, if a person has decreased lymph drainage, what is a potential cause? First of all, what causes lymph fluid to pump? I'm saying I can't hear you.
Oh, I said joint movements.
Okay, joint movements. So it's body movements are what cause lymph nodes to pump. So if a person is immobilized, they'll have decreased lymph drainage. If a person has decreased lymph nodes because they've had surgery, like usually because of cancer, they could have decreased lymph nodes as well. So, for example, women who have mastectomy, they also typically take nearby lymph nodes, and they can have swelling on that side of their body. And then if a person has a tumor, and the tumor can impinge on the lymph vessel and cause edema that way. So those are potential causes of edema that muck with those three mechanisms. Does that make sense so far? Now, one other thing you need to think about is one-sided edema versus dual edema. If you have edema in one leg, but not the other, is it most likely from a systemic problem or a local problem? Local. Would fluid overload be systemic or local? Systemic. So if a person has fluid overload or edema in one leg, sorry, erase that statement. If someone has edema in one leg only, is it because of fluid overload or something else? Something else. Does that make sense? So you need to think about it systemic versus local as well. All right, Dr. Heyman, this is inflammation. And when are we going to talk about inflammation? All right. Now, in order for this little system to work, what had to happen from this side to this side? What had to happen to that number to that number? Stayed the same. Stayed the same. It stayed the same. Why did it stay the same? What does it represent? What does the number that changes represent? Hydrostatic pressure. What does the number that stays the same represent? Plasma osmotic pressure. Why does it stay the same? You guys are going to kick yourselves when you find out how easy it is.
The blood still has the same.
Because you don't lose protein in the capillaries. So the protein levels are the same, arterial to venous. What happens if we punch holes in the capillary bed and we allow proteins to leak out? What would happen then? The osmotic pressure over here would be more or less the same, and now you've dropped your osmotic pressure down to, let's say, 10. And now you've got a whole bunch more fluid being retained up here. And that's what happens during inflammation. We call it an increase in capillary permeability. Sometimes you'll hear membrane permeability. Ability, can't spell. There's an I in there somewhere. You just can't see it. So, membrane permeability or capillary permeability. Your capillaries are made up of a single cell layer of cells called endothelial cells, and they are holding hands playing a game of Red Rover with the blood. How do you play Red Rover? You've never played Red Rover? Are you sure you were a child, or were you like a test tube kid? You just like, you have no memory before age 18, do you? Yeah. So Red Rover is a game that kids used to play. It's called Children. So you all hold hands, and you have two teams. So one team says, Red Rover, send Cindy right over. And then Cindy on the other team has to run and try and break through the chain. And if they break the hands open, Cindy will get to choose which person she wants to bring back to her team. So the goal, the trick, is you have to break between people who are strong enough that one of them is worth bringing back to your team, but not so strong that you can't break. Because if you can't break it, then you have to stay on their team. Does that make sense? So, you're playing Red Rover with the blood. What does that mean? The endothelial cells are trying to bounce the blood back in. Does that make sense? What else are they bouncing back in? Proteins. But during inflammation, something tells them to stop holding hands, to let go. And that allows proteins to come through. That is the mechanism for edema in inflammation. So the the mechanism is increased capillary permeability. Now, what's the purpose? Why do we want those proteins to be out in the tissue? You don't know, do you? Do you? Okay. How would they help damage the tissue? Or help repair the damaged tissue? But that's smaller than a protein. You don't need that. What's the number one protein? Albumin. What's the number two? Immunoglobulins, also known as antibody. Would it be helpful to have antibodies in the tissue? What was the number three? Would it be nice to have fibrinogen to help prevent the bacteria from getting into the blood? Some others that you might not be thinking about include complement cascade, which also helps to destroy invaders. So the purpose of edema is not to shift water into the tissue, it's to shift proteins into the tissue, and specifically the proteins that fight off infections and help with repair. So now we have learned what inflammation is, the 4 signs and symptoms, the mechanism of each symptom or sign, and its purpose. And along the way, you had to learn the normal fluid physiology that prevents edema, which is the interaction of what 4 principles? Hydrostatic pressure, osmotic pressure, lymph drainage, and then the last one, capillary permeability. So, on your test, in addition to the inflammation stuff, you're also going to need to know non-inflammatory causes of edema. Does that make sense? Now, we were just talking at lunch with the faculty members about the difference between what is called a content-driven curriculum and a concept-driven curriculum. What's the difference, do you think? Am I teaching you more content-driven or more concept-driven? I'm teaching you concepts. Here's 4 separate concepts. We've illustrated, or we've defined what they are, then we've illustrated how they work, and then we've given you examples. Now, for your test, you could go the content route and just memorize each of those ones. Things that can cause edema. And memorize every single one, and then what mechanism it is, and then whether it's systemic or local. Or you could try and understand the concepts so that when you're given any one of those, you can figure out which way it goes and what could happen as a result. Does that make sense? So when we think about plasma-osmotic pressure, what causes it? Proteins. Proteins where? In the blood. Where do those proteins come from? The liver. Well, what if you had a problem with the liver? Well, it wouldn't be able to make as many. So if a person has a low protein level or edema, you need to check their liver function. Where else do you get the proteins from? Well, from the diet. Well, we need to examine the patient's diet. Well, what if they're getting enough diet and they have a liver that works? Well, then what if they're not digesting correctly? So now look for inflammatory diseases. Does that make sense? So that would be more conceptual basis. You can get away with doing it content-driven memorization for a little while, but there comes a point where you can't memorize enough things and you get overwhelmed. So it's really important not just to memorize all the information, but to understand the concepts that underlie the information. Does that make sense? All right. At this time now, we're going to shift away from these first things to talk about some of the aspects of inflammation. Now, inflammation is kind of a complicated topic, and there's a lot of moving parts that all intertwine and interact with one another. So we're going to talk about some components first, and then we're going to kind of talk how they all fit together toward the end. And then we're going to introduce the immune system, and then everything gets wonky. So, some of the common elements of inflammation. Now, we talked about the vasodilation and heat. What is the purpose of the vasodilation and heat? To get more blood to the area. And one of the reasons we wanted more blood to that area is because we wanted to get white blood cells into that area. White blood cells can fight infections, and they can also help with tissue repair. Now, imagine for a moment that you're driving along I-95 and you see a sign that says, this is where I'm supposed to get off. What do you have to do to get off I-95? You have to go to the side, right? You don't exit from the center. You have to get to the side. Now, what is the side of a page called? The margin. So the first step is a white blood cell must get to the margin of the blood vessel, and that is called margination. Sometimes you wonder, do they just make up these fancy words just to make themselves sound cool? Well, the first step in the leukocyte's journey to the infection site is it marginates. Yeah. Why can't they just say it gets to the side of the blood vessel? The blood vessel is I-95 in this situation. Okay, so the first thing is it has to marginate. Now, the next thing it wants to do is it wants to actually exit. So here's a couple things that help it exit. The first one is, how many of you have ever used a hose before? If you want the hose to shoot farther and go faster, what do? You stick your thumb over the edge. There's less surface area, so it shoots farther and goes faster, right? If you want the water to go slower, what do? You make it wider. How many of you have gone whitewater rafting? How do you make the river more fast and turbulent? Make it more narrow. How do you make it slower and calmer? Widen the river. So that same thing occurs when you cause vasodilation. What has the artery done? It's gotten wider, and what happens to blood flow? It goes slower. So the white blood cells actually slow down as they get to the side. That gives them more chance to get out. Now, the white blood cell will begin to actually roll along the blood vessel. Now, what allows it to roll along, in part, is a change in the blood vessel itself. So the blood vessel begins to grow these little proteins that the white blood cell can stick to. And these are called VCAM. V for vascular. What does vascular mean? When you say cardiovascular system, what is vascular? I don't know. I took AMP2, but I learned the word, but I don't know what it means. Or are you just holding back on me? I just don't want to look stupid. Well, by not answering, it's too late. Because when you don't answer, I assume you just don't know it. What's vascular mean? It means vessel. Of or having to do with vessels. You're like, I knew it. Well, no, you didn't, or you would have said it. So I'm smarter than you are. No. You guys are crazy. So, you didn't say it loud enough. Yeah. One thing you should know, we haven't had this talk yet, is that I'm half deaf. So I put myself through nursing school in part by teaching dancing, dance lessons, Latin dancing, swing dancing, and when you go out to nightclubs that are entirely too loud, well, apparently what happens is you lose some of your hearing. So I can hear really well when the room is quiet, but when the room is not quiet, then I have no idea what you just said. I can hear that you said something, but I hear and then you guys mumble on top of that, so you think you said, it's blood vessels. But what I heard was, So, when you want to answer a question, what do you have to do? Speak loudly and enunciate. Because otherwise, it's kind of like the opposite of the Charlie Brown, or the teacher. What does a Charlie Brown teacher sound like? You never seen a Charlie Brown cartoon? Do you know who Snoopy is? Okay, so Snoopy's owner's name is Charlie Brown. And if you've ever seen any of the Charlie Brown cartoons, all the adults in the cartoon sound like this. Wom, 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 wom. So when you think you're answering under your breath, what I'm hearing is wom, 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 wom. So there you go. Vascular. So vascular means blood vessel. So what is growing those little proteins? The blood vessel. The blood vessel, the capillaries. So the little arterioles and capillaries are growing these little vascular cellular things, little proteins. So vascular, cellular, adhesion molecule. So it grows on the blood vessel and adhesive sticks to cells. What cells in particular? White blood cells. So your white blood cell is holding on to these little handles that have been conveniently exposed or grown by the blood vessel. And that's going to allow it to slow down even further. And then, because the capillaries are beginning to start letting go, they're not holding hands as tightly anymore, it creates a little spot where when this little white blood cell gets to this spot, it swings on through that thing and squeezes through. Now, how are you going to squeeze that through that? What do you think? You gotta squish it through, right? So it's going to look like this. And then eventually the whole thing will squish through. Sound effects included. Does that make sense? Now, this is referred to as a pseudopod. A false foot. Pseudopod. So the process of creating a second foot is called Diapedesis. I do not know who made this stuff up. Now it doesn't make any sense. This is a second foot. So the process is called making a second foot, diapedesis. Dia to ped, foot. So the first thing that happens to get a white blood cell out of the blood into a tissue is we marginate, get to the side. Second, it'll start to roll along the blood vessel, sticking to the VCAMs, which are exposed only during inflammation. Then it's going to swing through and squeeze out in a process known as diapedesis. All right, so that's what white blood cells do to get through. Now the question is, how do the white blood cells know to go there in the first place? Not GPS. It's a good guess. It's actually their nose. How many of you have ever seen a Fruit Loops commercial? Follow your nose. It always knows. How many of you know someone with a really good nose? Who are like, what's that? Like can smell chocolate. And they find the person with the chocolate. Hey, can I have some chocolate? Yeah. So the closer you get to the source of a smell, what happens to the smell? It gets stronger, more intense. So that same process is happening on a white blood cell level. There are certain chemicals that act as attractants, and they call these chemoattractants. I know you didn't see that one coming. So it's kind of like perfume that attracts guys. Oh, you smell good. My roommates don't smell like that. Thank God. So, the white blood cells are attracted to that chemoattractant, and they follow it in a process known as chemotaxis. So you can think of it as the white blood cells ride chemotaxis to the site of inflammation. At least that's how I think of it anyway. But chemotaxis is the process whereby white blood cells follow those chemoattractants to the site of infection or inflammation. And the other fancy name for those chemoattractants is chemokines. So, during inflammation, one of the things that is released that causes and mediates inflammation are these little chemicals called chemokines that attract white blood cells to the area. Does that make sense? Okay. Now, why does a blood vessel grow those little VCAMs in the first place? Or express them? Well, yes, but that's the purpose. But why did it do it? How did it know? Okay, so there's other chemicals that are telling other cells to do stuff. And those are called cytokines. Yep. Yeah, you guys should do like a crossword puzzle or something with this. So a cytokine is a chemical that affects a cell. So cyto is Greek or Latin for cell. So it is a cell alterer, cell changer. There are dozens of cytokines in your body. We'll give you some examples as we go along because some of the drugs that we have target those cytokines. So for example, histamine is one of the cytokines that's released during inflammation. And histamine has a bunch of different things that it does. But one of the things it does is it causes vasodilation. What does that cause? Inflammatorily speaking. You got nothing? Swelling. No. Indirectly, yes, but not directly. Redness and heat. Okay. Then it also causes an increase in nociceptor sensitivity, which you would think would cause pain. But in fact, it causes itching. And then the third thing that it does is it causes an increase in vascular permeability, capillary permeability. And what does that cause? That causes the swelling. So if we want to block the effects of histamine, what kind of drug would you take? An antihistamine. Does that make sense? So that's just to give you an example of one of the cytokines. There's dozens and dozens of cytokines, and some of them have very general effects like histamine. Some have very specific effects, so they just do 2 or 3 things. So we'll be learning about some more of those as we go along. But in general, what drives the process of inflammation are chemokines, which attract white blood cells to the party, and then cytokines that change the behavior of cells. Vasodilate, clot, sensitize nociceptors, increase vascular membrane permeability, express VCAM. All those different things are driven by what type of chemical? A cytokine. All right. Okay, in the notes, what is your next slide? I have to see if we have enough time. We actually talk about different cells now. Okay, so the next thing we talk about is a whole bunch of different kinds of cells. So let's talk about some of the cells that are involved in inflammation. So first we have white blood cells. What's a fancy word for a white blood cell? A leukocyte. Leuk is Greek for white, cyte Greek for cell, white cell, or white blood cell. Now, not all white blood cells are directly associated with inflammation, and we'll talk about those later when we talk about immune system. So right now we're just going to talk about the ones that are inflammatory in nature. The first one is called a monocyte. Now, how many of you, monos is short for monocytes. So how many of you have heard of a macrophage? Sometimes you'll hear macrophages and monocytes are the same thing, but they're not really. What's the difference between them? Monocytes come before macrophages. What does that mean? Differentiate? What does that mean? Specialize? Change? Transform. Oh, that's the word I like. I can understand that word. Okay, so you're using all the right words. So differentiate means to mature into. Now, how many of you have brothers and sisters? And when you were quite young, say 3 years old, you all kind of had similar looking faces. But as you grew older, your faces changed and you began to look more different. You ever see that happen in families? So as they grew up, their faces differentiated into their adult form. Little boys and little girls, like 3 years old, or even younger, say a year and a half. Sometimes you can't tell the difference, right? One of the most embarrassing things is, you go, oh, he's such a cute little boy. She's a girl. That's one of the reasons why a lot of parents pierce their daughter's ears. It's the only way to tell people that it's a girl, because the little girl looks like a boy. And then she grows up and doesn't look like a boy anymore. And then I remember my brother and I, my brother more so, he had this like curly blonde hair, and he also had blue eyes when he was a little kid. And we're like, oh, your girl's so pretty curly hair and those beautiful blue eyes. And now he's my 6'4" younger brother. Yeah. So that sometimes you can't tell the difference when something is very young. But as it grows and matures, you can tell that it changes and differentiates into the more mature thing. Does that make sense? Okay, so monocytes are immature macrophages. They have not yet differentiated into their final form. Another way to think of this is transformers. Now, I kick it old school when it comes to Transformers because I watched the original cartoon back in the 1980s. And so it's the Transformers, more than meets the eye. That's the Transformers. This Michael Bay nonsense, that is not the Transformers. Each Transformer movie gets worse than the last one. Have you noticed that? Like, you can't even tell what the plot of the last Transformer movie was. You're like, I don't know. I have no idea. But what we do know is that when they want to travel from one place to another, what do? They become cars and jets and helicopters and stuff. And then when they get to wherever they're going, what do? They transform into a robot so they can fight, right? So a monocyte is the car. It's the Autobot. And it's using the blood as a highway to get to the site of infection. And when it gets to the site of infection, it's going to marginate. It's going to roll along the thing. It's going to diapedesis. And it's going to then be in the tissue. At that point, it differentiates and matures into its final robot fighting form called a macrophage. Does that make sense? Oh, one thing I forgot to mention over here when we were squeezing that little white blood cell out, sometimes that process is called extravasation, extravasate. So that is just a generic term to mean go out of the blood. And it can also be used when you have an IV fluid that leaks into the tissue. So what does IV mean? Intravenous. So where is it supposed to go? In the vein. So if it's leaking and not going into the vein, but coming out of the vein into the tissue, that would be called extravasate, extravasation. Extra, outside, vasate, the vessel. So just so you know, that's another term that you might see sometimes used to describe the whole process. So when monocytes extravasate, they become macrophages. It's a one-way journey though. Once you become a macrophage, you don't go back and become a monocyte. Just like once you went through puberty, you couldn't go back and be a little kid anymore. How many of you mourned your lost little kidness? When you went through puberty, you're like, I don't want to be an adult. I want to be a little kid again. None of you want to be Peter Pan and the Lost Boys? No, I went full force. I had to get through puberty to get my driver's license, Dr. Heyman. You didn't understand. Nowadays, kids don't even drive. They just Uber. Whatever. So, monocytes become macrophages. Now, a couple things about macrophages. First thing is that we give them different names sometimes, depending on the tissue in which they live. So, if the macrophage is living in the brain, we might call it a microglial cell. If it's living in your liver, we might call it a Kupffer cell. Did you ever hear those terms before? Yes, you did in AMP2.
Can you spell the last one for me?
Kupffer. Named after Dr. Kupffer, who discovered them. If it's in your skin, you might call it Langerhans cells. Named after Dr. Langerhans, who discovered them. Yes, longer hands. You've got longer hands than me. But Langerhans sounds much more fun. If it lives in connective tissue, you might call it a histiocyte. They're all macrophages that happen to live in that tissue.
Are these really important to trust?
They might be. No, that's a yes. Yeah. When girls say maybe, it means no. When men say maybe, it means yes. Maybe. So, we change the names of the macrophages sometimes depending on the tissue that it lives in. Now, macrophages have both destructive roles where they destroy invaders and toxins, and they also have a regenerative or healing role as well. So in their destructive role, that's where they get their name, macrophage. What does macrophage mean? Macro means big, and phage means eat. So it's the big eater cell. And the reason is that they can eat hundreds of bacteria before they die. So the macrophage's job is to eat stuff that doesn't belong. Does that make sense? Now, sometimes, whatever it is just too much or too big or too powerful for the macrophages to eat and overcome by themselves. And when that happens, just like the Mighty Morphin Power Rangers, something special happens. Now, what happens when a Mighty Morphin Power Ranger can't overcome an enemy? I know you've seen the Mighty Morphin Power Rangers. Come on, admit it. They join together into a giant robot. Oh yeah, you see, you guys, you pretend like you don't know, but you know. So, what does the giant robot do? Well, it beats whatever the individual Mighty Morphin Power Rangers couldn't on their own, right? So, just like the Mighty Morphin Power Rangers, your macrophages can join together into a giant cell that can beat things that a regular macrophage can't beat. And that giant robot is called a giant multinucleated cell. Why is it called a multinucleated cell? Well, because each macrophage has its own nucleus, and when you join them all together, it's got lots of nucleuses, nucleolars. Now, what happens if even your giant multinucleated cell isn't enough to beat whatever it is? Now what do you do?
Make it bigger. Just kidding.
What if you can't beat whatever it is you're trying to beat?
It's a
It's a Skittle
you can eat that.
thing. It's been there for like 20 minutes.
Yeah, I know.
All right, so what happens if the giant multinucleated cell can't beat whatever it is? Do you just die? Well, yes. So what happens, so let's say that here's the monster, the bacteria or fungus that cannot be killed, kind of like Lord Voldemort. What we're going to do is we're going to surround the whole area with macrophages. We're going to ring the whole area, so there's macrophages everywhere. So we're going to wall it off. Then we're going to put down scar tissue. What is scar tissue primarily made of? Collagen. So we're going to kind of like create a net. And then we're going to put other white cells, lymphocytes, around that. And the idea is if we can't destroy it, we will contain it, banish it. And this is called a granuloma. So all of that goes on the destructive side of macrophages. We're not going to go into much detail about the regenerative side, except to say that it exists. So just know that macrophages will also be present in healing tissue, not just infected or damaged tissue for destructive purposes. Macrophages will also destroy your own damaged tissue to make way for the growth of new healed tissue. So you got to get rid of old tissue before you can regenerate new. Does that make sense? Okay. So that is pretty much the role of monocytes and macrophages. And it's about time to leave. So I think we have time to do one more. And that is going to be types of cells called granulocytes. Now, why do you think we call them granulocytes? What? They have granules. What is a granule? Yes, I mean, that is what it is. It's a little sac that holds something. But why do we call it a granule? Okay.
It looks like it under the microscope.
Under the microscope, when you look at them, when you look at the white cell under a microscope, it doesn't look like much. In order to see the granules, what do you have to do? Stain them. So when you stain it, then you can see the granules. And those granules are little vesicles of chemical warfare destruction. So there are three types of granulocytes. The first ones are called neutrophils. These are the most numerous of your white blood cells. It's like around 60% of your white blood cells are neutrophils. And they are also phagocytic. What does phagocytic mean? Phage, eat, cytic, cell. So it's a cell eater, just like a macrophage. But in the case of a macrophage, which can eat hundreds of bacteria, neutrophils can only eat 1 to 2 and then they're dead. So your body uses them kind of like shock troops. It's the very first white blood cell to come to an area of inflammation, and they don't last very long. Pus is made up primarily of whatever the bacteria is plus dead and dying neutrophils, if you've ever seen pus. Don't YouTube pus, okay? If you want to ever eat again. Anyway, neutrophils are the first to the party and the most numerous that we have. They typically attack bacteria, so you're going to see their numbers go up during bacterial infections. So high neutrophil levels are usually associated with bacterial infections. Now, In antibiotics, we talked briefly about bands, which are immature neutrophils. So a band is kind of like a teenage neutrophil. And what do teenagers do? They grow up. They grow up and hopefully mature into adult. So in this case, adult neutrophils. So we can judge the severity of an infection by how many bands are present. If the number of bands is high, that means that your body is putting out immature neutrophils before they're really ready for battle. Does that make sense? So immature neutrophils are called bands, mature ones are called, well, neutrophils. They're sometimes also called segmented cells because when you stain them, they look like their little granules are segmented. Their nuclei look segmented. They're also sometimes called polys because their nuclei are segmented and weirdly shaped. So that's called polymorphonuclear. Poly, many, morpho, shape, nuclear, many-shaped nucleus, also known as polys. So if you're in the hospital and you hear someone say the seg count was, what do they mean? Mature neutrophils. And if you hear someone say the poly count is, what do they mean? Mature neutrophils. Does that make sense? He's like, nope, got nothing. So it's just different names for neutrophils. Mature neutrophils are also called segs or segmented cells, and they're also called polys or polymorphonuclear cells. An immature, a teenage neutrophil is called a band. That's all you need to know as far as the different names go. Now, you do need to know what it means when bands are high. And what does it mean? The infection is more severe. All right. Next, and what do these destroy? For the most part, bacteria. If you see high neutrophil count, that's probably bacterial infection. The next one is called eosinophils, or EOs for short. So these are not phagocytic. The only ones that are phagocytic in this little area are the neutrophils and the monocytes, or macrophages. Eosinophils are not phagocytic, and they primarily attack worms and parasites. So hookworms, pinworms, filariasis, all the weird stuff you get when you go on a mission trip to Africa or China. Eosinophils kill those. Eosinophils also kill parasites like malaria. Eosinophils are also highly associated with certain types of allergies. Asthma patients often have elevated eosinophil counts. So they tend to be associated with histamine type reactions. And then the last granulocyte is called a basophil. And these are primarily against fungus. These are the lowest number of the white blood cells, like usually only about 1% of the white blood cells are basophils. Now, one of the things about these basophils and eosinophils is they don't just live in the blood. They also exit the blood and go into tissues. So we think that the eosinophil count and basophil count in tissues is often higher than what you see in the blood itself. All right, on that note, we are going to be done for today. All right, so the last time we met, we were just beginning to talk about the cellular components of the inflammatory system. So the very first ones that we had were white blood cells, also known as leukocytes. And the very first one of those we talked about was monocytes. And what's the fully mature version of a monocyte? It's a macrophage. And we use the analogy of a transformer. So monocytes are the Autobot car form. Macrophages are the robot fighting form. Except in the case of a monocyte macrophage, you can't go back. So once it transforms into that fighting form, it's done. That's what it's going to be for the rest of its life. Then we began to talk about the granulocytes, and the three granulocytes were neutrophils, which are the most common, and they are phagocytic like macrophages, but they can only eat 1 to 2 bacteria before they're dead. When there's purulent drainage or pus, the vast majority of pus is dead and dying neutrophils combined with the bacteria. And we also had to mention bands, which are immature neutrophils, and we learned about those already in antibiotics. So just to refresh your memory about the shift left, shift right. So bands become neutrophils. So when you have an increase in bands, we call that a shift to the left. Now, you can only use that terminology if there's an increased number of overall white blood cells. Fancy word for that was leukocytosis. All right, so neutrophils, then we had eosinophils, and eosinophils are named, well, they're named because they stain with a stain called eosin, but IgE is an antibody that gets its name from eosinophils because it binds to eosinophils. IgE, immunoglobulin E for eosinophil. And that makes it very highly, makes eosinophils highly related to allergic reactions, and then also helps to fight against parasites, so things like worms or malaria. A lot of times patients have allergic reactions, they'll have increased number of eosinophils, so like patients with asthma, for example. Then the last one was basophils. And basophils are also white blood cells, but the vast majority of basophils are not found in the blood. They're actually found in tissue, and we're not exactly sure all of their functions, but they seem to have a function in fighting funguses. So I think this is right where we left off last time. Is that right? Okay, so now new things. Next we have something that is called a mast cell. Now, mast cells are kind of interesting because they don't live in the blood. But we think that they were originally white blood cells. So we think they started off in the blood, produced in the bone marrow, and then they migrate out into the tissue where they live. So a mast cell can also receive IgE antibodies, and it can also degranulate when it's activated. So they've got these little granules in there that are filled with little bags of chemicals, and when it's stimulated, it's going to release those granules. So there's more than 17 different substances that are released by a mast cell when it degranulates. But the number one, about 40% of it, is histamine. Now, what does histamine do? How many have ever been stung by a bee? What happens? You swell up. Why do you swell up? Because of histamine. How many of you have allergies and you take an antihistamine? Well, what does that antihistamine do? It blocks the effects of histamine. So histamine is a cytokine. Remember we talked about that word earlier. A cytokine is any chemical that alters the behavior of a cell. So in this case, histamine is a cytokine that causes vasodilation, and it causes increased membrane permeability, and it's also going to sensitize nociceptors, which is actually not going to be perceived as pain in this case. It's going to be perceived usually as itching. So that's why antihistamines have an anti-itching property. So we'll talk a little bit more about first and second generation antihistamines a little while later when we talk about drugs. But for now, histamine is about 40% of what a mast cell releases. Now, why do histamines not really work that well? Well, because 60% is other stuff. So there's an enormous number of inflammatory mediators. And one of the things that you have to understand about the immune system and inflammation is that it's incredibly complicated. And we're just talking about some brief little spots. So we're sketching And we're doing the big things, and we're trying not to get lost in too many nitty-gritty details. And you're like, really? You're being incredibly detailed, Dr. Heyman. But in fact, I'm not really. It's just, that's what the immune system is. Welcome to nursing. So, those are mast cells. Then we also have natural killer cells. Now, natural killer cells are kind of interesting because they are also considered part of the immune system, but they aren't really immune. Anyway, so they can come from either lymphocytic tissue or they can come from what's called myelogenous tissue. I haven't mentioned those words yet, have I? All right, quick little primer on how blood is made. We start off with what's called a pluripotent stem cell. What does pluripotent mean? Plural. None of you know English, okay. What's plural mean? Many. Many, potent. Ability. So it can become anything. It can become many things. So that pluripotent stem cell can become all different kinds of blood cells. And you guys should have learned this in A&P, right? Right? Hematopoiesis. What? So this then is going to turn into either a myelogenous precursor, or progenitor, I believe is the correct term, or a lymphocytic precursor. And the myelogenous can in turn become, eventually, through a series of steps, red blood cells, monocytes, all of your different granulocytes, all three types we just talked about, and mast cells, and platelets. And then over here you got, and natural killer cells. And then over here you've got lymphocytes, which are three different types. And then, natural killer cells too. So natural killer cells are interesting because they come from both sides of your pluripotent stem cell tree. Now, this is not going to be on your test, but it might help you to understand the overall process. Say it again? Red blood cells, monocytes. Monos. Yeah. So, red blood cells, monocytes, granulocytes, I can't even read that one myself. Mast cells, platelets, and natural killer cells are all myelogenous. And then, I actually have a slide on this in the PowerPoint, so you can just reference that. And then lymphocytes come from the lymphocytic precursor or progenitor, and natural killer cells come from both. I feel like I'm repeating myself, because I am. Now, natural killer cells have an innate ability to kill cells that are infected with either viruses or to be able to kill cancer cells. So they kind of do a little bit of inflammation and a little bit of immunity at the same time. Then we have a cell called a dendritic cell. Now, dendritic cells are a really interesting case because they were discovered back in the 1970s, but they didn't really show up into your textbooks for pathophysiology and nursing and A&P until the mid-2000s. So it was like a 40-year time span in between the time that they were discovered and then when you guys had to start learning about them. Now, how many of you have ever heard of something called Langerhans cells? Langerhans? Yeah. Named after Dr. Langerhans, who discovered them. What are they? We actually mentioned them last time when we talked about macrophages. Deer in the headlights. I got nothing. But you said you'd heard of them. No, actually, Heyman. What I said I'd heard of was Isles of Langerhans. What are those? Oh. They're in the pancreas, and it's where your beta cells that secrete insulin live. Well, Dr. Langerhans also discovered some cells that became named after him that live in the skin. And macrophages that live in the skin are called Langerhans cells. But it turns out that there's another kind of cell that lives in the skin that is also called Langerhans cells, and those are dendritic cells. So a dendritic cell was so named because they are shaped kind of like this. And so the guy who discovered them said, well, it looks kind of like dendrites from a neuron. So they named them dendritic cells, which have nothing to do with nervous tissue. Go figure. So the dendritic cell is also a cell that came from that pluripotent stem cell on the myelogenous side. And it has a couple properties. One is it's phagocytic, so it can eat nearby cells. And it is also what is called macropinocytic. Now, how many of you are familiar with a whale? A whale. Like, do you know whale? Yeah. Your inner, channel your inner Dory. Okay. So, how does a whale eat? It opens its mouth, and it sucks in an enormous amount of seawater, and then it closes its mouth, and then there's these little ridges called baleen, and it goes, and it squirts the water out. And whatever's left it behind, it eats. And what kind of food is that? Oh, look, krill. Yeah, plankton and krill. So it's going to eat them that way. So that's what these do, is it sucks in a whole bunch of the nearby extracellular fluid, and then it filters it out to see if there's anything that it might have missed. And then once it's eaten something, it's going to process it. And it's going to chop it up into little pieces, and it's going to go, that tastes healthy. That tastes okay. That tastes like normal stuff. That's bad. I got to do something about this. And when it discovers something bad, it's going to travel through the lymph to the nearby lymph node, where it's going to start asking lymphocytes, do you recognize this antigen? Do you recognize this? Do you recognize this? And it's going to try and activate T-cells. Now, when you took ANP2, or maybe it was ANP1, you talked about the immune system. What was it that activated T-cells? Dead silence. No, this is where you tell me something. Nope. I'm pretty sure you did not learn that. Good guess. Usually we say macrophages. How many of you heard that? Macrophages activate T-cells. You ever heard that? Yeah, you heard that? You heard that? No? Only one of you heard that? The rest of you were in a different ANP2 class? So that's often what we're taught, but as it turns out, that's not really the case. Now, if you put macrophages in a test tube along with T-cells, they will activate them. But in your body, it turns out, most of the time, what activates a T-cell is a dendritic cell. So dendritic cells activate T-cells and start the entire immune process. Without dendritic cells, we don't have an immune response. All right, these are the cellular components of inflammation. And then we have some chemical components. So the first one we're going to talk about is something called complement. That's a lovely sweater you've got there, Ariana. I said, that's a lovely sweater you've got there, Ariana. But that's not what we're talking about, is it? When you pay a compliment to someone, how would you spell that? With an I. And if you got something for free from a hotel, that would be considered complimentary, with an I also. So what does it mean when we have an E? Complement. They work together. Maybe you should think of Jerry Maguire. You complete me. You had me at hello. So in this case, complement is going to complete or help the inflammation process do its thing. So there's two things we need to know about complement. The first one is, how is the complement cascade, it's a series of enzymes that activate one another. That's why it's called a cascade. The reason for that is because this very dangerous process, and it can cause an enormous amount of harm to whatever it attaches to. So you don't want it just randomly activating in your bloodstream. You really want it to be activated in a certain spot at a certain time. So that's why you have the safeguard of a series of enzymes that activate each other. That's called a cascade. In this case, the complement cascade. So the first thing is, how is this complement cascade activated in the first place? And as it turns out, there are 3 pathways. How many? 3. So the first one, interestingly enough, is called classical. And it involves complement cascade 1, C1, binding to something. And as it turns out, there are 3 somethings it could be. So the first thing it could be is an antigen-antibody complex. Now, what is an antigen?
Anything that stimulates an immune response.
Anything that stimulates an immune response. That is a very good answer. It's slightly technically not correct, but it's good enough for us. Technically, it's anything you can produce an antibody against. So, what is an antibody? It's a little component of your immune system that attacks antigens. And it's kind of circular when you define it that way, isn't it? But who cares? That's how we do it. So, when an antibody binds to an antigen, that is called an antigen-antibody complex. And antigen-antibody complexes, C1 can bind to that. And then that activates the complement cascade. The second thing it can bind to is something that is called C-reactive protein, also known as CRP for short. Now, what is the major source of proteins in your body? A major factory of proteins? It's your liver. So where does C-reactive protein come from? Your liver. Now, does your liver produce it all the time or just sometimes? Well, I don't think you'd be asking the question if the answer were all the time, so I'm going to go with sometimes. Okay, great answer and good thinking. Now, the most important question is, when does your liver produce it? Since you got the first answer right, smarty pants.
Not me.
Not me, I was in the smarty pants, don't look at me. You know the absolute best way to volunteer? Make eye contact. Now I see a couple of you are like, I will never make eye contact again.
Is it when you have an infection?
Well, hold on, I'm telling a joke here. So the second best way to volunteer, you know what it is? Avoid eye contact. Okay, go ahead and ask your question.
When you have an infection.
That's close. Now, what did we say inflammation was? What's the definition of it? The response to injury. And what was the descriptor that we used for inflammation? No, those are signs and symptoms. What's the description of the overall process? Starts with an I.
Immune response.
No. Does it start with an I? No, I'm having a hard time thinking about that. That's what happens when you get old. You forget stuff. It starts with an N. An N. And the second letter is O. And the third letter is N again. Non. You guys are good. You can spell out loud. Non-specific. All right, so inflammatory processes are non-specific. What does that mean? It means it doesn't matter what kind of injury, it'll always happen the same. So let me ask you this, Ashley.
Yes.
Does your body produce C-reactive protein during infection? Only infection or other times too?
Non-specific.
It's non-specific. So what would be a better answer?
Non-specific.
Yeah. When does your body produce C-reactive protein?
Whenever it needs to in non-specific cases.
In non-specific what?
Injury.
Inflammation. Yeah, so any inflammation, your body, your liver specifically, will start producing C-reactive protein. So C-reactive protein is sometimes what is known as an acute phase protein. So during the acute phase of inflammation, your body will produce C-reactive protein. Now, a little sidebar for Pathopharm 2. When we get to cardiovascular diseases, atherosclerosis is when your arteries build up goo in the middle, right? Well, in the middle, inside the artery. And that can eventually lead to strokes and heart attacks. As it turns out, in order to have the atherosclerosis process occur, you need inflammation of the artery. But it's a very small, tiny amount of inflammation. And if you use a regular CRP test, you can't even tell that it's there. So when you're trying to detect cardiovascular inflammation, you use what is known as highly sensitive CRP. And that is, if that is high, it's a potential sign that the patient has arterial inflammation, which is leading to atherosclerosis. That will not be on your test, so you can erase it out of your memory now, until you get to Pathopharm 2, in which case you'll have to bring it back. But C-reactive protein, not only is it something that can activate the complement cascade, it's also something we can measure to see if there's inflammation present. Does that make sense? So when is C-reactive protein produced, Ashley? No, when?
In the liver.
When?
When there's non-specific inflammation.
When there's inflammation. You can just say inflammation. So,
You said the last time, so it's wrong.
no, you said infection. Yep, that's what I meant too on the test. So make sure you're using the right words. I know I don't always use them the right way, but on the test I still expect you to use the right way. So when does it occur?
When there's inflammation there.
Inflammation. And not only does it activate C1, but we can use it as a lab value, and we can check CRP levels. If they're high, what does that mean? Inflammation is present. What kind of inflammation? Can't tell. What kind?
Can't tell.
Can't tell? Okay. You got to do the hand motions in the face, or it doesn't work. You won't remember it otherwise. All right, so that is the second one. And then the third one is it can actually bind directly to some pathogens, primarily bacteria. So if C1 is binding to something, that is considered what pathway? The classical pathway. And what are the three things it can bind to?
C-reactive protein and directly.
Directly to what?
Some pathogens.
To a pathogen. All right. The second thing, the second pathway, is called the Mannose-binding lectin pathway. So mannose is a sugar that is found in the cell walls of some bacteria. And during inflammation, your liver produces something called mannose-binding lectin. A lectin is a protein. So it's a protein that can bind to this sugar that's only found in bacteria. And so if it binds to something, you know it's a bacteria, right? And if the bacteria shouldn't be in that spot, then you know you should kill it. So that's what happens there. Now, when does your body produce mannose-binding lectin?
Bacteria present. Non-specific. Yes.
So when?
When there's a non-specific Specific.
You don't have to say that word. It's inflammation. Yeah. So anytime there's inflammation, your body will produce mannose-binding lectin. What kind of protein does that make mannose-binding lectin? An acute phase protein. And then the third pathway is called the alternative pathway or spontaneous. And this is when it just occurs in the blood spontaneously. And this is very, very dangerous because this can lead to inappropriate immune responses or inflammatory responses. So, 3 pathways: classical, mannose-binding lectin, and spontaneous or alternative. The classical has 3 subpathways. C1 is going to bind to the antigen antibody, C-reactive protein, or directly. Now, that's the first thing you need to know about complement. How is it activated? The second thing you need to know is, what the heck does it do? Well, it complements. Okay. So let's talk about the 3 ways that it complements the inflammatory response. So the very first thing it does is it increases inflammation. The second thing that it does is that it can actually kill some bacteria. Would you like to know how? Oh, me too. How many of you have ever seen this little plastic device, like a little plastic tube with some like little cut out holes in it, and you're supposed to like screw it into an orange and then you can drink out of the orange?
Oh, yeah.
What did we say about bacterial cell walls in the last chapter for antibiotics? What was the purpose of that bacterial cell wall? To prevent something. What was the something? Lysis. Why would a bacteria just lyse if it didn't have a cell wall? Because it's hypertonic. So if you poke a hole in the cell wall, to quote Chaucer from A Knight's Tale, its entrails become extrails. Actually, that wasn't Chaucer. That's what the other guy threatened Chaucer to do. Have you guys seen A Knight's Tale? You've never seen A Knight's Tale? Do you know who Heath Ledger is? He's in that. Oh, okay, I'll watch it now. I've been alive longer than you have, so that's part of it. But you should watch A Knight's Tale. It's a very good movie. You guys don't get the jokes at all anymore. It's okay. So,
We're constantly studying.
yeah, well, at least you knew the little device that doesn't work when you screw it into the orange, but hey. So, here's a bacteria, and what we do is we create this little series of proteins that goes down into the cell wall and forms like a little straw, and it pokes holes into it. And then it lets the guts spill out. So it punctures the cell wall, allowing the guts to come out, killing some weaker bacteria. Now, this little thing that does that is called the MAC, the membrane attack complex. So what's responsible for killing the bacteria? The MAC, which stands for membrane attack complex. And how does it work? It pokes holes into the membrane, to the cell wall, allowing the guts to spill out. And to quote a movie you haven't seen, its entrails become extrails. All right, and the third thing that it does is it opsonizes. Now, that was interesting. I don't even see what kind of, nope. It's just dark now. Hello, darkness, my old friend. Okay. So opsonize. This one can be a little bit difficult if you're not familiar with military hardware. But there's a kind of a guided missile that requires someone to point a laser at the target. It's called a laser-guided missile. Bet you didn't see that one coming. So what you do is you've got someone who's got a little laser pointer, and they point their little laser at whatever the target is. And when the laser hits the target, the missile can see that, and it's going to hit it. It doesn't actually see the laser. What it sees is when the laser breaks up by hitting the object. Does that make sense? Doesn't. You guys don't care. The process of hitting the target with a laser is called painting the target. So as long as you're pointing the laser at someone, what are you doing with them? You're painting them with a laser. You're marking them to be destroyed by that missile. Does that make sense? Okay. When you've got this bacteria that's got this little MAC sticking out of it, that is a signal to macrophages that they should come over and eat it. So it's kind of like it's been marked, but instead of with a laser, it's been marked with what? A MAC. So the MAC paints that cell as a target to be destroyed by macrophages. So then macrophages, which are kind of big, dumb, and ugly, oh, okay, I'll come and eat this thing. Does that make sense?
Might not be relevant to the MACs like survive to go off to another one, or is it?
Well, it's just a protein, so it gets broken down into amino acids again and recycled or pooped out or whatever. Yeah. Not part of our problem. So this process of painting a cell to be eaten by a macrophage is called opsonize. And the thing that does the opsonizing is called an opsonin. So what is the opsonin in this case? Not the macrophage. What does the painting, not the eating? The MAC. Yeah, the membrane attack complex. I can see how that could be a little confusing. The MAC does the macrophage? Yeah. Okay, whatever. So those are the three things that complement cascade does. Does that make sense? So what are the two things you need to know about complement cascade? How it's activated, the three pathways, one of them has three subpathways, and no matter which pathway starts, in the end, these are the three things that it does. Does that make sense? All right. There are quite a few autoimmune diseases that are caused by inappropriate activation of complement cascade, typically from the antibody-antigen complex. And we'll talk all about those when we talk about allergic reactions. So, at this time, we only have one more thing that we need to talk about for the chemical component, and that is a chemical called tumor necrosis factor alpha. Now, originally it was called tumor necrosis factor alpha. I am not aware of any betas or gammas personally, but what I can tell you is that lately there's been a trend toward just calling it tumor necrosis factor, or TNF, without the alpha. But since I'm old school, I'm saying alpha. Whatevs. You don't care. Now, tumor necrosis factor alpha is a cytokine. What does a cytokine do? What is a cytokine? It's a chemical that alters the behavior of a cell. Right. Okay, so in this case, it's going to do three particular things. The first thing is it's going to cause vasodilation. Does that sound familiar when it comes to inflammation? Yes, we want to get more blood to the damaged area, so therefore you have to vasodilate. So far, so good. The next thing it does is it causes increased membrane permeability. Does that sound familiar? Yes. In order to get complement cascade and antibodies to the damaged area, you need to increase the membrane permeability so they can leak out of the blood into the damaged tissue. So far, so good. The third thing that it does is that it increases clotting. Now, Does that make a lot of sense to you?
Well, if inflammation is caused by injury,
You might have damaged blood vessels, and clotting off those damaged blood vessels might be a good thing. Okay. As it turns out, macrophages secrete tumor necrosis factor alpha during inflammation. And it makes a lot of sense in terms of that damaged area needs these things to happen. But there's a problem. What happens when a bacteria escapes out of that damaged tissue into the bloodstream? Now what happens? What happens to that little bacteria? I'm free! So it's floating around in the blood, bopping around, and eventually it goes through an organ. Are there some organs that are responsible for filtering your blood? What are they? Say again? Lymph nodes or lymph. Kidneys do filter your blood, but they're not meant to filter out cells. So the spleen. Now give me another one. Spleen's over here. And one over here too. The liver. So the spleen has a huge number of macrophages in it, and your liver has macrophages in it that are called, we named these last time. Oh man. Kupffer cells. And those macrophages in your liver and in your spleen begin to go, hey, there's bacteria in the blood. And they start to secrete their tumor necrosis factor. But where do they secrete it? Instead of into the damaged tissue, now they're secreting it into the blood. So now you get vasodilation all over the body. What does that do to your blood pressure? Vasodilation all over the body. What does that do to your blood pressure? So that decreases it. In fact, if it decreases it too much, what could that lead to? Shocking. What kind of shock would that mimic where you have vasodilation? Neurogenic shock. So how might you treat that? What do you want to do? You want to vasoconstrict. What's the fancy name for a drug that causes vasoconstriction? We haven't said this word yet in class, so we'll just see how smart you are just generally now. Okay, vaso, good. What's the word when you push on something? Another word, if you push a button, what would be another way to say that? Press. Vasopressors. Vasopressors. So drugs that cause vasopression or vasoconstriction are called vasopressors. And name 2 vasopressors that you are aware of. You had to do this just on the last test, by the way. What receptor is responsible for vasoconstriction in the sympathetic response? Alpha 1. All right, now name 2 alpha 1 stimulators. I'm sorry, I can't hear you. Okay, I still can't hear you, I'm sorry. That is an alpha 1 blocker, not a stimulator. Okay, phenylephrine is a good answer. Pseudoephedrine, not so much. That's more for your nose. Phenylephrine for your nose too, but it can also be given IV for this purpose. I was going to say catecholamines, including dopamine and norepinephrine. So, treatment for a patient who's got this problem would be phenylephrine, dopamine, and norepinephrine. Not all 3 at the same time, please. Increased membrane permeability. What is that going to do?
It allows the white blood cells to travel into the damaged tissue.
Okay, well, it allows white blood cells and, more importantly, proteins. But when the proteins exit, what does that do to a certain kind of pressure? What kind of pressure would that be called? It's not hydrostatic pressure. Is it?
Osmotic.
Osmotic pressure. So it decreases the osmotic pressure. And that allows what symptom to occur? Edema. Now, where is the edema occurring? Everywhere. So you actually have edema systemically. And water that's in edema is water that's not in your blood, so that is actually going to decrease your blood volume. And what kind of, could that lower your blood pressure? Yeah, it can lower your blood pressure. And what kind of shock might that simulate? Hypovolemic shock. So, by the way, if you haven't figured out yet, this is how septic shock occurs. Bacteria escape into the blood. They get filtered in the spleen and the liver, which the macrophages there secrete tumor necrosis factor alpha, which causes these effects. And that's how your patient ends up in septic shock. Now, so what is the ultimate cure for septic shock? Antibiotics, you got to get rid of the bacteria in the blood. But the patient is probably going to die before you do that. So to keep them alive along the way, you're going to treat their neurogenic looking shock with alpha-1 or vasopressors. You're going to treat their hypovolemic looking shock with increased fluids. And then we got to deal with this problem right here, increased clotting. Now, where's the clotting going to occur? Everywhere. So what's a fancy word for saying spread out? Now, you're never going to guess. I'll just tell you. Disseminate. Yeah. So the word literally means to cast seed or spread seed. Like in the old days, like in the Bible, there was a man who was casting seed, and some of it fell on the path, and some of it fell on the good ground. And you remember that? Yeah, anyway. So in this case, we're going to spread the clotting throughout the entire body. So the fancy word for that is disseminated. Helps we know how to spell. Disseminate. Spelling these wrong. Disseminated. Now, what's the word for inside a blood vessel? What was the word for inside? Intra. And what's the word for vessel? No, it's not. But that wouldn't have made you less wrong if you just said the answer outright. So intra, vascular. Oh yeah. So vascular means of blood vessels or of vessels. And then, what's a fancy word for clot? That's a very good fancy word, but let's think of a different fancy word. Starts with a C. It's kind of like congeal. Coagulate. Yeah, I knew that was what it was. Sure you did.
That's bad at pronouncing, but I can say that loud.
Mm-hmm. I believe that. So, if you take the first letter of each word, what do you get? D-I-C.
I wasn't going to say it.
Yeah, I know. That one is way too hard, Dr. Riemann. Yeah, this is not an acronym. It is a abbreviation. So what's an acronym? That's when the first letter, that's when an abbreviation forms a new word. So like laser stands light amplification stimulation by the emission of, light amplification by stimulated emission of radiation. L-A-S-E-R, laser. Bet you didn't know that, did you? You don't know laser. You've never seen that movie either, have you?
Yeah, that I've
Okay, fine. At least you know one movie. Melody's like, nope. Got nothing. All right. So it's not DIC, which would be an acronym. It's DIC. It's an abbreviation. So DIC is a problem that happens when you have septic shock. And so you're going to have clotting inside the blood vessels spread out through the entire body. And that's going to cause two problems. The first one is clotted blood thicker or thinner than regular blood? thicker. So it's going to cause the viscosity of blood to go up slightly, which makes it harder for your heart to pump the blood around. Imagine trying to pump toothpaste instead of water. You get the idea. It's not that bad. It doesn't turn into toothpaste, but slightly thicker than regular blood. That's not a huge problem, though. The big problem is do you have enough clotting cascade and fibrinogen and platelets to clot everywhere all at once? No. So what happens to your clotting material when you're trying to clot everywhere all at once? I got nothing? Well, let's not skip to the end. So you start to clot everywhere, but you don't have enough clotting material to go around. So what happens? All right, let's use a different analogy. If you want, right this moment, can you go out to a store and get toilet paper? But if everyone went out at the exact same time to get toilet paper, what would happen? No toilet paper left, right? They run out. Okay. How many of you have been here during a hurricane? What happens? You go to the store and there's like nothing. There's no bread, there's no eggs, there's no ice, there's nothing in the store. Why is that? Because there's not enough food in the store for everyone all at once. So what happens? The store runs out. You try and clot everywhere all at once, but you don't have enough clotting material for all at once, so your body runs out. Then what happens? No, not yet. Don't kill your patient just yet. What's going to happen before they die?
Blood will be able to go through the body.
If you can't clot, you bleed. So, patients with DIC bleed to death. They're going to be hemorrhaging from everywhere.
Wait, you said clotting the blood vessels. How would you bleed everywhere?
You start off clotting, and then you run out of clotting factors.
And then the blood just comes out.
Yeah. So, if you've ever seen a movie where they have a hemorrhagic fever like the Hot Zone or Outbreak, this is what happens when they all start bleeding to death. So these patients are going to be bleeding out of their eyes, out of their nose, out of their mouth, out of the IV site. They're going to be bleeding everywhere. Now, to keep this patient alive long enough for the antibiotics to work, vasopressors, fluids, and now we've got to replace clotting factors and platelets. How do we replace clotting factors, do you think? Okay, well, we will give blood because they're going to be losing blood. Okay. All right. But how can we replace the clotting factors themselves? What part of blood do clotting factors live in? Well, it's not the cell part. What's the water part called? Plasma. So, if we take some fresh plasma and we freeze it, what do we get? Fresh frozen plasma. So, to keep the patient with this alive, DIC-induced hemorrhage, you're going to give, first of all, packed red blood cells, PRBCs, and you're also going to give them fresh frozen plasma, which is going to have clotting factors in it. And they might also need platelets as well. Now, patients with DIC will sometimes have 20 units of each of these a day. And they could be in DIC for multiple days. So one single patient can be using up 60 units per day, 20 of each one, just to keep that patient alive for one day. So how many of you gave blood when the blood mobile was here the other day? None of you?
They turned me away.
They turned you away. You can't give blood. Such excuses. If you were a hero, that's what the shirt says. Anyway, if you had given blood, you would have had to have 19 of your other fellow students go with you just to provide 1 day of one patient on DIC. So these patients are, there's a song that describes their situation, knocking on heaven's door. Knock, knock, knocking on heaven's door. You know, the song is old now. It's from the 50s, you know, Bob Dylan. And then Eric Clapton sang it, and then Guns N' Roses sang it, but you guys were born after Guns N' Roses were popular. Ask your parents about Guns N' Roses. All right. So anyway, these patients are going to die unless we do something heroic. We've got to treat their shock, treat their shock, treat their shock, and treat their bleeding. Does that make sense? So, septic shock is caused by TNF-alpha run amok. How do you spell amok? All right, well, there's two amoks. The amok you want is M-A-M-O-K. If you spell run amok, M-U-C-K, that's like you're running into mud, which is not the same as running around crazy, killing people you shouldn't be killing, which is amok. So, TNF-alpha, tremendous power for good under the right circumstances. What are those right circumstances? You got nothing? Where do we want TNF-alpha to be released?
In the blood.
No! That's what causes this. Into damaged tissues. Yeah, you're like, I told you nursing school makes you dumber. It's already happening. So, TNF-alpha gets released into damaged tissues. Good. So you can think of TNF-alpha as Spider-Man. But with great responsibility, with great power comes great responsibility. And you can think of TNF-alpha in the bloodstream as as venom. He wants to be a hero, but he's really a villain. Right? Yeah, you guys didn't watch that Venom movie, did you? Yeah, well, I heard it was terrible, so I haven't seen it either, but see, you don't know the new movies either. Ha! Okay, so TNF-alpha in your tissues, good. TNF-alpha in the blood, bad. Causes septic shock. What are the three components of septic shock? Vasodilation, increased permeability, and DIC, which leads to hemorrhage. To treat that, you need all of that. Packed red blood cells, fresh frozen plasma, and platelets. Up to 20 units a day, or sometimes even more. So these patients are enormously expensive to keep alive. But we can do it. We have the technology. And you guys don't understand that because it's from The Bionic Man, which was in the 70s. Okay. Sorry, it's okay. If only you knew your pop culture. All right. So, on that note, we are now done with the components of the inflammatory system. And we are going to move over to this side of the board, and we are going to talk about the immune system. Now, what was the single word that was the best word to use to describe inflammation? Non-specific. So over here, when we describe immune, we should use what word? Specific. All right, smarty pants. Specific to what? Nope. Nope. Closer. Antigens. Okay, so when we're talking about specific, we're specific to antigens. So let's talk just a moment about antigen. Now, earlier you had said that an antigen is anything you produce an immune response to, and technically that's called an immunogen. So, is there a difference between immunogens and antigens? Kind of. So, close enough. Now, immunogens or antigens are multi-part. So, it's the same theory that we use to describe the interaction of a receptor and a drug, or a hormone and a receptor. And what is that theory? Lock and key. So imagine for a moment that you had an antigen that looked like this. Okay. Now, how many is one antigen? But how many potential antibodies could we make against this thing? 3. One that recognizes triangles, one that recognizes circles, and one that recognizes triangles, or ears, eyes, and noses. So there's 3 potential antibodies that can bind to this one antigen. So this antigen is called multivalent. How many have ever heard that term before? You've heard it? All right. Sometime, how many of you got your flu shot this flu shot season? What word is used to describe your flu shot? It's usually trivalent. What does that mean? 3 different strains of virus. So you can produce 3 different kinds of antibodies against that one thing. There's also a quadrivalent, which means you can produce 4. So 4 different strains, 4 different kinds of antibodies. So this is called multivalent. Now, the exact portion of the antigen that you can produce the antibody against, the part that would bind to the antibody, that is called the epitope. Tope, T-O-P-E. Now, if you separate out the epitope from the rest of the antigen, then what's left over is called a hapten. Now, let's apply this newfound knowledge to penicillins and cephalosporins. What was the portion that people are actually allergic to? The beta-lactam portion. Maybe. So, maybe not. But they have this little structure in common. So this is might be a hapten or it might be an epitope. We don't know. Does that make sense? Maybe for some people it's an epitope, maybe for other people it's a hapten. But either way, there's something in common between cephalosporins and penicillins that allows them to cross-react. So that's the same principle as our bunny, which now looks more like a panda. Anyway. It was a cat, but now it looks more like a bear. That's what happens when you put a circle around the nose. Yeah. Okay. So, back up to here now. The cells of the immune system are going to be specific to epitopes, or more generally to antigens. And each of them is only going to be able to recognize or bind to one single antigen, or more specifically, one specific epitope. Does that make sense? Okay, now I'll give you a hint. The cells on this side are all called lymphocytes. So where do the lymphocytes come from? Where are blood cells made? In the bone marrow. All right. From what? I wrote it on the board earlier. Pluripotent stem cell becomes a lymphocytic progenitor, and then eventually down to the different types of lymphocytes. Remember that? No, it doesn't matter. I said it wasn't going to be on your test anyway. Just seeing if you're paying attention. So, you guys are conserving your energy, your mental energy, by not memorizing things that aren't on the tests. I can appreciate that. So, lymphocytes, there's multiple types of lymphocytes. Now, They all come from the bone marrow, but some of them grow up in the bone marrow, they stay home. And we call these B cells, B for bone. Others of them go off to college in the thymus gland, and we call these T cells, T for thymus. So we're going to talk about T cells first. Now, how many of you are in college right now? None of you? Oh, okay. 2 of you. Okay. Why did you go to college? To learn. I'm just here to learn, everybody. To get an education, to get a degree, to make the big bucks, to have choices in life. That's why you chose nursing, right? Because you can go anywhere and get a job anywhere, and if you get bored of one job, you can get a different kind of job, and you can do all these flexible things, and you got choices. So, when you go to college, what do you get? Choices. And in the case of a T cell, it has 2 choices. It can become either a manager or a secret agent. Now, what does a secret agent do? I have no idea. What's a secret agent? Okay. How many have ever heard of communism? The Soviet Union? Okay. Nazi Germany. Now, in each of those areas, there were certain people whose job it was to look at the citizens of the country and see if they were rebelling or had rebellious thoughts against the regime. What? Kind of like a spy, but instead of spying on other countries, you're spying on your own people. So in the case of Germany, they were called the Gestapo. And in the case of the Nazis, well, partly KGB. KGB did both. They did internal and external spying. So what was the job of the secret agent under those countries? To spy on their own people, right? To see if they were turning to the dark side. Now, can cells in your body turn to the dark side?
Yes.
And attack your own body in some way? Yes? Really? What kind? Under what circumstances?
Either we have like an autoimmune disease or cancer.
Okay, well, let's not say autoimmune disease because that's a problem with this itself. So let's say cancer. All right, so cancer is one of your own cells mutates on you and starts trying to take over the whole body, right? What's another situation where a cell can turn to the dark side and start working against your own body? What happens if there's a little thing called a virus? What does virus do? What do viruses do? I mean, you all got right that HIV is an infectious etiology, right? So what do they do? What does a virus do? How does it replicate? It has to infect a cell inside your body. We call it a host cell. And then it takes over the cell and turns that cell into a little virus factory. So the 2 major ways that our cells turn to the dark side, one is cancer and the other is viral infections. So secret agent cells, their job is to check out your body cells and go, are you going to become cancer? Are you virally infected? And if they are, what does it do? Kills it. So, what's the fancy word for cell? Site. What's the fancy word for kills or dangerous to? Toxic. Put those together, what do you get? Cytotoxic. How many have ever heard that before? Cytotoxic. My pen is running out of dry erase magic. This is not technology, it's magic. It's okay. Oh yeah, I only have pink. Hold on. Oh, right. Yeah. Ninja-like reflexes. Okay, so secret agents are called cytotoxic cells. Now, to give this secret agent its, if you were a policeman, how would you know someone was a policeman? The uniform, but you can buy uniforms at Halloween stores. A badge. So we're going to give these cells badges. It's a special protein that lives on the cell membrane, and that special badge is called CD8. Wow, that's dark. It's like this magic is strong. Okay, so CD8 is a protein that's on the outside of the membrane of these cells and identifies them as cytotoxic cells. Now, the CD8 protein is not just for show, it's actually a receptor. So, in order to be able to examine your body's cells have a special protein called major histocompatibility complex, MHC. And there's two types of MHC. So, every cell that has a nucleus, what's inside a nucleus, by the way? DNA. What is the purpose of DNA? It's the instructions for what? Close. It's the instructions on how to make proteins. It's blueprints. So every cell with DNA has the potential to do what? Make proteins. So as it's making proteins, what it's going to do is it's going to display those proteins on this special molecule called MHC1, Major Histocompatibility Complex 1. Every cell in your body has MHC1 if it has a nucleus. And so our CD8 cell, the CD8 has the ability to bind to MHC1. And that's how the cell is able to look. So, let's say that N means normal proteins. So the CD8 cell comes along and it says, hey, what kind of protein you making there? And it goes, normal proteins. It's not exactly how it works, but you get the idea, right?
Yeah.
Okay. And then the cell goes, okay, CD8 will keep going, carry on, do whatever you're doing. But if this CD8 cell recognizes, let's say it's producing noses. So this is a virus, not a bacteria now. So if it's producing noses and this can detect noses, then it goes, you're evil. You've turned to the dark side. You're an angry elf. You must die! And it tells the thing to die. Now, what's the fancy word for telling a cell to die? Starts with an A. Apoptosis. Some people will say it apoptosis, but you know, what's a ptosis among friends? So, apoptosis. So this cell will tell it to commit suicide, and if it doesn't commit suicide, it actually has the ability to kill it itself. That's why it's called cytotoxic. Now, CD8 cells are responsible for doing this and seeing if it's producing abnormal proteins. Cancer cells sometimes produce abnormal proteins, so it can kill cancer cells. And if it's got virally infected proteins, if that CD8 cell can detect that particular kind of protein, that epitope, it'll tell it to kill itself. Does that make sense? Okay. Now, what if the cell has the wrong kind of MHC? Then what happens? So, I can't even tell what kind of protein you're making because your MHC is all wrong. What do you think it would do?
They just like naturally kill it.
They would naturally kill it. Could that be a problem? How could that be a problem? What kind of person would that be a problem for? Someone with a transplant. We take someone else's organ who has a different MHC, and we put it into your body. And now your CD8 cells come along to see what kind of proteins it's making, and it's like, wait a minute, this is all wrong. You got the wrong MHC here, buddy. I gotta kill you. And it destroys the organ. So to prevent that from happening, what would we need to do to a patient who's had a transplant? Okay, we can give them immunosuppressant. Now, before we even do the transplant, what else could we do? What we want to do is we want to find a good match. What does that mean? We're going to do genetic testing, and we're going to see how similar or far apart the MHC is. So patients who have more similar MHC are going to have less severe, they call it transplant rejection, or transplant graft rejection. People who have very dissimilar MHC are more likely to have stronger and faster rejection reactions. So, in addition to issues with cancer and with viral infected cells, CD8 is also responsible for transplant rejection. All right, so that is secret agents. Now, what's the other thing that we said that a T cell could choose in life? Nope, the B cells stayed at home in the bone. T cells went off to college, so they could have choices. One choice was to be a secret agent, and the other choice was to be a manager. Now, how many of you have ever had a really bad manager? How does a bad manager act? Screams at you. It tells you what to do and then tells you how bad you are at doing it. And they never do what? Oh, they'll correct you plenty. You're doing that wrong.
They'll never teach you?
Okay, they'll never help you do it right. So what do you think we might call these manager cells? Helper T cells. Does that ring a bell? Okay, so helper cells. Helper cells, their job is to manage other immune cells. Help them do their job better, just like a good manager. And as it turns out, helper cells get a further choice. They can choose to specialize in either helping macrophages or helping B cells, which we haven't talked about yet. So I'll put B cells on here just so we can show them. So our managers have two types. Type 1, what does type 1 manage? Macrophages. What does type 2 manage? B cells. Does that make sense? Okay. Macrophages, remember it said that they're kind of big, dumb, and ugly? Or no, big, dumb, and stupid? So they're kind of directionless. They have to be told what to attack. And what do T cells do? They manage the macrophages and they help them to know what to attack. Does that make sense? Okay. And then B cells, we'll talk about those in a few minutes, need some help as well. And so type 2 cells specialize in helping B cells. All right, so at this point we need to talk about the life cycle of a T cell. Let me know when your brains are full. We'll take a small break. Okay. Now, or keep going? Does that mean keep going or does that mean take a break?
Let's take a break.
Okay, let's take a quick break.
I'm good.